71-year-old gentleman, came to see me with persistent urinary symptoms after a prior aquablation procedure for an enlarged prostate approximately 18 months prior. And his symptoms had gotten a little bit better after the surgery, but then had quickly recurred within about 6 months. He was taking full-dose tamsulosin or Flomax medication as well as finasteride, was having to strain to urinate, urinating frequently, getting up multiple times per night, weak urinary stream, and just really unhappy with his quality of life. He felt like he wasn't emptying his bladder well, and this was leading to him not wanting to leave the house. Prior to the aquablation, his prostate had measured somewhere around 160 to 170 cubic centimeters, which is a very large prostate, and had not been remeasured since his aquablation surgery. I chose to perform a whole-up surgery because it does extremely well in very large prostates as well as prostates that have failed prior surgical intervention. By utilizing the plane between the transitional zone and the peripheral zone, I'm operating in an area of the prostate that is generally unharmed by other surgical procedures, and it's very easy to complete the surgery by working in this surgical plane. As the patient and I worked through his symptom, it became apparent that he had suffered from retrograde ejaculation prior to the aquablation and after the aquablation, most likely because he needed to continue his medications. So a lot of men will choose procedures like aquablation or other missed procedures in an attempt to preserve their ejaculation. But if they have to go back on their medication, we're not preserving their ejaculation. So as we talked about whole-up, one of the downsides is that you do develop retrograde ejaculation. So I discussed with the patient that that's really not going to change because you already have that. But the benefits would be you'll urinate better. You won't need to take medications again. You won't have intermittent bleeding. And the procedure will likely last the rest of his life because we're removing all of the tissue and creating a nice wide open channel that could take 20, 30 years to ever regrow. Unique considerations in doing a whole-up in patients who have undergone prior surgical intervention is really scarring and bleeding. So these patients are at increased risk of developing urethral stricture or bladder neck contractures because they've undergone so many procedures. You also can tend to get quite a bit of inflammation, and so the tissue will be more inflamed and have more bleeding risk, and that you have to prepare for going into the surgical procedure. If a patient is on blood thinners or has a bleeding disorder or prone to bleeding, I will do the surgery at a setting of 2 joules and 60 hertz instead of the standard 2 joules and 50 hertz. That's more hemostatic, and it delivers more energy to the tissue to limit bleeding. I will also keep those patients in the hospital overnight, and then the next day we take their catheter out. They still are at higher risk for bleeding complications, but we can lower that risk from about 30% down to 10 to 12%. Whole-up is often the only surgical procedure these people can have done because they can't discontinue their anticoagulation or blood thinners due to clotting risk or heart disease. So it's really fulfilling to help people who are in these situations suffering with their urination and have no other option. So this is the cystoscopy of our patient who had previously undergone aquablation. And I'm looking in the interior of the prostate using my laser scope. The lateral lobe has actually merged together in what we call synechia. You see this inflamed right lateral lobe. The left lobe's been treated somewhat. And then there's these bridges of tissue that connect the two. And this will often happen when you leave residual tissue. You can also see some scarring near the sphincter. As I pull back into the urethra, here's the sphincter and there's scar tissue right there. We're gonna leave that alone in hopes that it does not disturb his continence. But you can see these inflamed bridges. And this is the unfortunate consequence of doing a procedure in large prostates where you leave tissue behind. So the very first thing I have to do is cut these skin bridges or scar tissue bridges between the right and lateral lobes so that I can get down to the bladder neck and get to the capsule. I usually do a setting of 2 joules and 50 hertz. Because this gentleman was so inflamed, I changed the settings to 2 joules and 60 hertz to just control those bigger inflamed vessels. And I'm just going to work back and forth very quickly to make this incision, and I'm trying to work my way all the way down to the capsule. Now, I know I'm at the capsule when I stop seeing this fluffy type tissue. It's still quite fluffy here, so I know I have not reached the capsule. A lot of people will say, how do you know? And it really is how the tissue behaves with the laser, how it interacts with the laser. If it stops fluffing, then I know I've reached the capsule. I also will see more blood vessels at the capsule as well, and that's a good sign. But this prostate's quite large. When we remeasured him, he was still 160 cc's, so very little change in the size of the prostate from pre-aquablation to post-aquablation. And as I work down through here, you can see that there's some of this like black char. I think it's pieces of metal from the TURP that they do at the end of the aquablation. So a lot of times with an aquablation, they'll do the aquablation and then put a TUR loop in and burn the area. And if someone's had a TURP, especially quite recently, you'll get these little black char specks. So you'll see that throughout this video, and it's really just little metal pieces from that TUR loop, I believe. But we're getting very close to the capsule here, and I control the bleeding as I go. If I don't do that, it will really get out of control. So you just need to take the time to stop and control bleeding. And I'm checking the length. I can see that there's the viru. I've not come back too far. Now I'm going to extend that cut under the left lateral lobe. You can see that the plane between the capsule and adenoma has really not been disturbed at all. The prior surgery did not get deep enough into this plane to make a difference, so I can easily peel up that tissue and define the capsule here. And I'm working it towards that cut I made at 6 o'clock and controlling the bleeding as I go. And I'm just gently lifting up the left lateral lobe and releasing the attachments. So I'm continuing to lift that left lobe up. And now I'm just rotating my scope around the apex. I've lowered my laser energy to 2 joules and 20 hertz, and I do that when I work around the apex. 1, because I don't want to transmit energy to the sphincter, but 2, it's a tight space and there's not much irrigation flow. And so if you put high laser energy with low flow, you get a lot of charring. So I'm using that 2 joules and 20 hertz to develop the plane, and then I pull back into the true lumen, and I'm just going to score this urothelium from about the 5 o'clock position up to the 12 o'clock position in what we call an apical release. And that's just releasing the urothelial attachment between the lobe and the sphincter. Now I go back in and I continue to develop that plane between the adenoma and the capsule, with adenoma below me, capsule to the lateral side of me, and using that laser energy to release this. It's not that typical beautiful hole-up that you see because he's been operated on before, so not all the planes always connect easily, but you can see just by going back to that baseline, I can find the plane again. So now I'm going to do the same thing on the opposite side. So I make the cut under the right lobe at 2 joules and 50 hertz, and again controlling the bleeding as I go so that it doesn't get out of hand. And then I'm going to put the scope in and I'm going to twist it clockwise this time and use that 2 joules and 20 hertz to release the right apex. So that's adenoma on the right side with capsule on the left side, and using that lower energy to just release those apical attachments up to the 12 o'clock position. And then I will eventually pull the scope back to cut the urothelial strip that is holding this lobe to the sphincter. And so by releasing the apex early, we've released the stress on the sphincter. We are limiting the tugging and pulling so that we do not get any bruising or damaging of the muscle. So this is the most difficult step of the whole-up surgery, whether it's in a redo case or a virginal case. It just requires a lot of training to do this well. But once you learn this, you never forget how to do it, and it becomes quite natural. As I'm making the turn, I'm constantly moving forward. So once I've released the apex, I'm moving the scope forward with the laser, trying to get up to that 12 o'clock position. And you can see now I have actually met the plane that I created on the other side. And I'm just going to release this area of urothelium here, and now the left and the right lobes are connected apically. So the full apex has now been released. Once you've met the left apical turn to the right apical turn, then I develop the anterior plane. So I'm going to wiggle the scope between the adenoma and the capsule. So I have adenoma below me, capsule above me, and then I'm going to use that laser energy to release the attachments moving forward. It's very important that you marry the right lobe to the left lobe at this time, because you do not want to create multiple planes. That will become extremely confusing. So take the time to make sure all your planes are lined up before you start working your plane forward. And I'm wiggling my scope in again. I use a 28 French continuous flow laser scope. I like the 28 French, especially in redo cases or in flame cases, because you get better flow, better visualization. So now that we're moving forward, you can see that I'm encountering more and more of these bleeding vessels. This is where you're seeing a little effect from the aqua ablation, which is interesting because most aqua ablations leave quite a bit of anterior tissue. In this patient, I'm guessing he had some TURP done anteriorly, which is why there's not that much tissue left in this space. But it's coming down nicely as I work forward. I'm just resetting myself again, making the turn again to get my scope in a little better to develop that plane. And as I'm working forward, I'm constantly trying to rotate the scope up and down and around to move the laser towards the bladder neck. My goal here is just to release that whole anterior plane and get through the bladder neck fibers. Oftentimes with a redo, you won't see these beautiful bladder neck fibers like you normally see with a standard hole-up. It's usually resected to control bleeding. So you really have to follow that plane between the capsule and the adenoma. And now I'm just going to catch up the right side. I've done a lot of work on the left anterior plane, and I'm going to catch up the right anterior plane to make sure all my planes move forward in the same direction. Now, this gentleman has a large amount of what we call an anterior lobe, so tissue that's sticking into the bladder, and it's extending forward quite extensively. So it's taking quite a bit of time to develop this plane into the bladder neck. If I develop any bleeders up here, right now I'm working at 2 joules and 60 hertz, but if I encounter a bleeder, it's often easier to use the second pedal, the 2 joule and 20 hertz, to just get gentle control. The difference between using the 2 joules and 50 hertz and the 2 joules and 20 hertz is the 2 joules and 20 hertz, you can actually touch the bleeding vessel, so you don't have to gauge how far away. Whereas with the 2 joules and 50 or 2 joules and 60, you actually have to defocus the laser fiber, which can be kind of tricky for individuals who just do not do a lot of hole-up. So I say when you're first starting out, use the right pedal for your hemostasis. As you get more experienced, you can start working with defocusing the laser to control bleeding. So this plane is developing beautifully. You can see that beautiful capsule above and the fluffy adenoma below, and the bleeding is responding well to the laser. And I'm just going to extend that out all the way to that left turn to make sure this full anterior plane is married up. Especially in a redo, you just do not want to create multiple planes. This will just make your procedure last so much longer and more confusing. So I'm going back to that right apical turn to ensure that it's married up to the anterior plane that I've created. So I'm almost done with this anterior plane. Another thing that you can see is I have very little laser fiber sticking out. So I just adjusted the laser there. I think a mistake I see learners do is they put a large amount of laser fiber exposed, and you can't get good traction, counter traction when you do that. You just want a very small amount of laser fiber exposed. You don't worry about injuring your scope because you have a protective laser catheter, and you want just enough exposed so that you can get your scope right next to the tissue and create that traction, counter traction. So we're almost through the bladder neck. You can see how the tissue is changing. It's getting more stringy in appearance, and that's a sign that we're coming up to the bladder neck. And we're encountering more blood vessels as well. So as you encounter more blood vessels and see the stringy tissue, you know you're in the right place. Another mistake that I see people make is they think that the prostate is flat, straight, plane, and it's actually more like a globe. So after you hit the equator, you have to start pointing your laser downwards. Otherwise, you'll extend the plane up above the bladder. And you can see that I'm just developing these bladder neck fibers as I move forward and keeping that plane all in check. So we've got, half of the prostate enucleated now, still in that upside down position with the scope. Before we've even gotten through the bladder neck fibers. Now right here, this is the scar of the bladder neck fibers where they did the cleanup TURP after the aqua ablation. And it's really our first look into this patient's bladder. If you remember at the beginning of the surgery, it was so scarred we couldn't get the scope in to the bladder, but now we're actually able to get the scope in on the anterior plane. And you can start with the anterior dissection in patients where the bladder neck is too high, or maybe they're obese or the prostate's too big and you just can't get the scope into the bladder. The anterior plane is much shorter than the posterior plane, so 99% of the time you'll be able to get the scope in by developing this plane and dropping the prostate down, and then you can inspect the bladder and complete the case. It's a really nice bailout technique in a difficult situation, which is to start with that apical turn and then develop the anterior plane to get into the bladder. So we've released the whole bladder neck anteriorly. I'm just going to control some of the bigger bleeders. You almost invariably see bleeding at that 3 and 9 o'clock position at the bladder neck. And now I'm just going to take this lateral plane down more on the right side and again control bleeding as I go. The key to keeping these cases calm is to control the bleeding as you go. Some people get so excited that they see the plane that they don't want to stop and control the bleeding, but then it can get out of control pretty quickly with a lot of large bleeding vessels, so just take your time. So now I'm coming around the right apex there and joining that turn with the anterior plane. Next, I'm going to divide the prostate in half. I don't necessarily have to do that. You could do what people call an en-bloc technique, leave it all together. But I find that it's much easier to manipulate the tissue, to deposit it into the bladder, and then to subsequently morcellate it if you cut it into at least 2 pieces, if not 3. So in this case, I'm cutting it into 2 because he didn't have a defined median lobe. So I'm just dividing from the true lumen to the anterior plane. Using the laser, I'm just going back and forth to release the right lobe from the left lobe so that we have 2 completely separate prostate lobes. It makes it just so much easier to deposit the tissue into the bladder and to work with these large prostates. Smaller prostates probably doesn't make much difference, but once you get up above 150, it's just so much easier to develop that traction, counter traction when you're working with a smaller piece of tissue. So it's almost released, and you can see how inflamed that right lobe is. It's just a large inflamed mass, and it's no wonder that he has persistent symptoms. So as we near the bladder neck, I'm up over that right lobe. Anterior plane is completely developed. We've got this large right lobe, smaller left lobe, and I'm just going to go ahead and work on this right apex now. So I'm going to take that anterior plane and drop it down to the apical turn and release this right lobe. As I work, I call this working the corner. I always start with a corner when I do the lateral lobes. By working the corner, you're ensuring that you're not making multiple planes. So I'm bringing the scope back near the sphincter. I've rotated it so that I'm working at that 7 to 8 o'clock position, and I'm dropping the lateral lobe down in a lateral to medial motion. Working lateral to medial is not natural when you learn this procedure. Most everyone wants to put the scope under the lobe and rotate it forward to develop the posterior plane. But if you take the time to just develop the lateral plane first and drop it down from your anterior plane that you created, it will be a much smoother and much more efficient procedure. Now I'm nearing the bladder neck, and I can see that anterior plane I created at the bladder neck, and I'm just making the lateral plane here meet that anterior plane at the bladder neck. So I'm slowly releasing, and you can see I'm rotating the laser fiber. So I've got the tissue on traction with the scope, and I rotate the scope to get the laser where I want it. Unlike other surgeries like TURP or green light, where you really don't do a lot of scope movement, HoLEP requires big scope movements. So you're holding the camera in place and then rotating the scope with the opposite hand. And so as I work towards the bladder neck, there's more bleeding. Very common to encounter significantly more bleeding at the bladder neck. So I just take my time to control those bleeders in this area. This prostate also extends significantly into the bladder, so I have to drop that down. And to avoid injuring the bladder as I do this, I will oftentimes turn off my outflow so that the bladder will become extremely distended, or turn it down. I'm looking for the ureteral orifice to ensure it's not close to where I'm going to laser, but I really want to get that bladder over distended so that it will float away from where I'm cutting. I think a lot of ureteral orifices injuries occur when people get the bladder too deflated or drained, and then they accidentally back wall as they take down the bladder neck. So just by turning off your outflow, you can prevent that. Obviously, you want to turn it back on within a few seconds, but turning it off for a few seconds or just down for a few minutes will help you significantly. So I've taken down most of this lateral lobe on the side, and this is the bigger prostate lobe. I usually tell people to do the smaller lobe first, but I think in this case it was just very natural to get this side out. But when you're first starting out, you really actually want to take the smaller prostate lobe out first, and then take the bigger lobe out second. So now I'm rotating down and around. It is a little bit scarred here, but not bad. Really more of a concern in this case is the bleeding. So I'm continuing to develop the plane underneath the right lobe. Some big inflamed blood vessels here. And now I'm starting to rotate under that lobe towards the median cut, which is at that 6 o'clock position. I do have a couple of different planes there, so I'm going to marry them up despite my best efforts. I'm going to take the lower plane because I think it's better to get under that nodule that's been created. A lot of times when people have been on finasteride for many years, they will develop very nodular prostate. So the prostate can seem more like an onion than just a perfect orange, and there's several different layers. So as long as you pick the deepest layer you can get to that safely, and make sure all of your planes are in that layer, you're fine. Sometimes you'll have these very deep nodules. I try not to dig them out if they're really deep under the bladder neck, but if they're in the lateral capsule, I will definitely dig those out. I don't want those to bleed or increase the PSA. So this patient's PSA was 6.5, and after the procedure dropped down to 0.8. And it's because we're just getting all of that PSA producing adenoma out of the way. And you can see that it's just the capsule remaining, and that makes very little PSA. So it does make monitoring for prostate cancer much easier because the PSA test becomes far more sensitive. Any little changes in the number we know is abnormal, and it's not from BPH tissue, it's from something else going on. So another big vessel here, and this beautiful capsule is really showing itself to us. So the adenoma is rotating medially. We're picking up speed now since the plane is real obvious, and releasing that adenoma from the right capsule. This patient is going to have a great result just getting all of this inflamed tissue out. You can see how the capsule is very smooth. At the apex, it was kind of fluffy and nodular. There's always a sticky part to every prostate, and it's usually near the apex, around the 5 to 7 o'clock position on each side, and you just have to work through that and go back to your lateral planes. Now I'm underneath the right lobe, so I've done as much as I can laterally, and now I have to develop this posterior side of the right lobe to get it to deposit into the bladder. So I've repositioned myself at the 6 o'clock position, and I'm rolling the tissue forward and rolling that prostate up. I actually see people struggle with this part more than the others. And I think what happens is they're very excited that this is nice and easy. It's right in front of them. But they tent up the capsule as they roll the tissue forward. So they create too much stress. And then they accidentally perforate the capsule. It's a very delicate balance between rolling the tissue up and over pushing the tissue forward. So I'm connecting that lateral plane to the posterior plane now to make sure those two planes stay connected. And it's a nice blow for freedom there as I connect the posterior plane to that lateral plane and the tissue starts to roll up. As I get closer to the bladder neck, I really need to push the laser upwards. If I keep working straight back, again, I can perforate just like anteriorly. So I have to think about it as a globe. So on the posterior side, once I hit the equator, then I have to start hedging upwards to avoid perforating through the capsule. And this prostate, again, is very vascular, very nodular, and it's because of the prior surgical intervention. To control these really big bleeders, I will usually just defocus the laser and then just laser in that area to create heat to weld the vessels together. So as I release this bleeder here, I'm just going to really, lack of a better word, just cook it with the heat of the laser and get it to stop. So some people, I think, want to move away from the bleeder because they want to see it perfectly, and a lot of times you just can't do that. So you just have to be very patient and let the tissue heat up. So we're continuing that posterior side, again, rolling forward. This adenoma actually tucked up way underneath the trigone as well. So it's a long ways under that bladder neck to roll it upwards. Another question I get asked often is, do you worry about undermining the trigone? And I never really actually think about undermining the trigone. I just think about following the plane and allowing itself to present itself to me. I'm going to take out all the tissue, and so if that creates a little divot under the trigone, so be it. This capsule will collapse down, and so it's very unusual for patients to have difficulties with catheter placement or cystoscopy after a hole-up because the capsule will collapse and you can get any type of catheter in easily. And this little corner here right at the bladder neck can sometimes be difficult because you can have adenoma that jets up laterally under the corner. So taking a little extra time to release it before rolling the prostate forward is always helpful. And you can see as we're working, the more I release this prostate, the less it bleeds. So I'm rolling that tissue forward, and it's almost into the bladder. So the balancing of these large lobes can be somewhat difficult. So what I will often do in these situations as well is turn the outflow down, so I get a little more distension and a little more room to work, and then I just roll that tissue into the bladder. So we're getting back to those last few attachments of that right lobe, and I'm rolling that tissue up into the bladder. It's the bladder neck. Again, releasing those attachments to get this large lobe in, and that's where I controlled the bleeder before. So I attempted to roll that in, but still could not get it to deposit, so I'm just going to keep trying to release edges of the prostate until it deposits forward. So you can see if I was just working with one large piece instead of dividing the tissue in half, that would be even more difficult to deposit it forward. So I think with the big prostates, you really are better off doing a 2-lobe technique than an en bloc. So just continuing to just try and get underneath this lobe to get it to deposit into the bladder. It's quite a bit of work because it's so large, but we're getting there. There's very few attachments left of this lobe, and I'm almost into the prostate. I keep checking the bladder neck to make sure I'm in the right plane. You don't want to push really hard. If you push hard, you can actually push through the capsule. I'm actually rotating my scope upside down to just release that attachment more at the bladder neck because I can't quite reach it. And I'm really, using all my skills to get it to flip at this point. So now I've gotten it to rotate up more and flip forward, and I've gone back to the left lobe of the prostate to release that. So probably the hardest part of this whole case was getting this right lobe to deposit into the bladder. Sometimes I'll come up around the side of the prostate, and that will release the tissue into the bladder. And it's ever so slightly getting a little more released each time as I roll it forward. Now I've finally gotten it to flip, which is great. And voila. So now I will rotate the scope down the bladder neck to get those last few attachments on the right side. You can see it sometimes will come off in like a V-type formation, which I find quite interesting. So I will drop the scope from the lateral down the V to get that last little tip. I think some people cut straight across and they'll leave a big chunk of tissue. You really want to think about it as a V. So I'm connecting that right side of the bladder neck to the first cut that I created at the very beginning. I can see the char from my first cut there too. And the last few attachments are coming off here. I am also leaving my outflow down a little bit again to get the bladder distended so I don't back wall the trigone as I release this tissue from the bladder neck. And I'm doing that very soft V from right to left, working down the bladder neck. You don't want to work from medial to lateral because the tissue can rotate away. You can see that I found the ureteral orifice right there and all this inflammation. Now I'm going to pull back and I'm going to let that last little bit of urothelium flip up to me as I cut it. So I'm just going to repeat that again. This is what I call like the pull back technique. So I just pull the urothelium back away from the ureteral orifice to prevent an injury, and then I cut it while it's on tension. It takes a little bit of practice, but it works very well to prevent injuring the ureteral orifices. And this is just the most satisfying part of the whole case. As you see this release, and you just know that this is not going to be a problem for this patient anymore. You can look at that, like huge cavity left. And that's just the right lobe. This is really what this patient needed to get rid of his symptoms once and for all. It's just a nice, beautiful cavity. No perforations, very little bleeding. I'm going to take just a minute to control bleeding. I do this before I do the second side, again, just to get anything big that could be problematic and obscure my visualization before I finish up the prostate on the other side. And there's always a little bit of bleeding around the viru. It's very common. You can't really do much about that. But now we're going to go back to this left side and get this release. So I start at the left apex again, and I'm just going to take that lateral upper plane and have it meet posteriorly. The second side always goes so much faster and easier because you have room to work now. You've created a huge space. The tissue wants to roll into it. It's just so natural and easy for that tissue to rotate medially, and I can connect that anterior plane to the posterior plane. Now this is real time. This has not been sped up. So a big prostate like this is about a 20-minute enucleation if you use this technique. And I spent quite a bit of time rotating that right lobe into the bladder. But once you get that out, this left side goes so fast. It's quite easy. So I'm dissecting that left apex, you can see there's a lot of big bleeders back here that I just, again, control as I go. A lot more inflammation than what you would see in a standard prostate. I think when we talk about using HoLEP in people who have failed prior surgeries, actually the most difficult in my experience has been tuna. We don't see a lot of patients who have had tuna. It's not performed anymore, but there are still some patients out there who have had it done, and that procedure creates a lot of scarring deep in the prostate. So I think that is probably the most challenging. Aqua ablation, green light, TURP, they create a lot of inflammation, so you have to be prepared for more bleeding, but usually the plane is pretty good. A good TURP will sometimes make the bladder neck and the posterior plane difficult. Rezum can create pockets inside the prostate, urothelialized pockets that you have to understand are there and not get lost. But overall, it's not too difficult as well. And then UroLift is quite problematic, not in that it's hard to do the enucleation, but the UroLift clips will actually jam the morcellator, so it makes morcellation more difficult. So I'm releasing the bladder neck right here. You can see that there's like a released area below, and then this attachment laterally. And this will sometimes happen, especially in patients who have had prior TURP procedures or aquablation or something where the bladder neck's disturbed. So I'm just releasing that scar tissue that's holding that left lobe to the bladder neck here. I'm turning down my outflow again so I don't back wall the bladder. And I pretty much do that every time I get close to the bladder neck, just so I don't inadvertently hurt something in the bladder. So I'm going to come back again and do exactly what I did on the other side, which is rotate this tissue forward and then release those attachments. I'm not touching the tissue with the laser. I use a no-touch technique. I feel like it's more efficient and bleeds less, which is what I believe allows me to get the patients out of the hospital the same day without a catheter. Just a real beautiful plane posteriorly on this side for this gentleman, and it's joining the other plane nicely. And here's that sticky area that all the prostates have. His is a little closer to the bladder neck, but we're releasing that nicely and rotating this lobe down into the bladder. So this area around the bladder neck right here is an area that often can perforate. So you just have to make sure you're truly following this plane and not extending too far laterally or not tenting up the capsule as you rotate the tissue medially. And there's not a lot of blood flow at his bladder neck there, probably from the prior procedure. So as this opens up, you will see some scarring. Again, you see that metal deposit near the bladder neck. So you can tell they did the aggressive TURP maneuver at the bladder neck right there, which has created that scarring and that metal deposit. So when we do HoLEP, all the tissue that is taken out is sent to the pathologist. So even though it's morcellated, they can actually look at it quite well. And about 13% of the time we find undiagnosed prostate cancer. The vast majority of the time it's low grade, low stage, and patients are put on active surveillance, but they're getting a diagnosis long before they ever would have known about it by standard just biopsy and testing. So that's a definite benefit of getting HoLEP is that you do get kind of the ultimate biopsy. You're getting about 70 to 80% of your prostate removed, and that tissue is all being analyzed so that you know what is in there long before it may have ever made your PSA rise or cause any other symptoms. So we're almost done with this left lobe, and I'm releasing the attachments as it rolls forward. And again, this is so much easier than the other side. One, it's a smaller lobe, and two, I've created that great space by removing the other lobe. As I come forward here, you can actually see the urothelialized defect at the bladder neck from the prior surgery. It looks kind of hyperinflamed up there. I'm not going to try and remove that. There's nothing to be gained by doing that. And it looks like it's well healed. So if there is no adenoma in a spot of the prostate, I will not try and remove it from the prior surgery. So sometimes after an aquablation or a TURP posteriorly, there's very little tissue. It's just lateral tissue. So I'll leave the posterior plane alone. This gentleman had a lot of tissue everywhere, so we had to remove it all. But in some cases, I might just take out a lobe or the anterior plane. And now I'm just going to release that urothelial attachment there and release this lobe downward. So because the cavity is so big from the other lobe, I actually don't even have to flip it forward. I can keep it in place in the fossa to release those attachments. And now I'm just going to try and flip it forward into the bladder. I'm going to over-distend things by turning off my outflow and flip the tissue in right here. And this is just so satisfying to see this cavity created. Now, right below, you can see that capsule is tented up. So I'm looking at that V. You have to really make sure you don't get misled and think that the tented up capsule is actually adenoma. You'll see a nice V created between the adenoma and capsule, and that's where you want to cut. If you try to take out the capsule, obviously you'll perforate. So at this point, when you've flipped it forward, you will look for the V, and that is the perfect place to cut. Then it will release the capsule back down. So now I'm going to just release that last little attachment. And we're almost done with this lobe. So you can see why, after I've done this, that HoLEP has such a long-term result. I mean, this is basically a continuation of his bladder. There's nothing left to regrow. I've not disturbed that area near the sphincter that we talked about at the beginning. The viru is untouched, and he's just wide open. So medication doesn't really have even much effect after this procedure. So before I morcellate, I always go through and I do just what I call a drying up. Anything that's red, I take care of with the laser to ensure that it's not going to obscure my visualization during morcellation. I think it's so important to have good visualization and morcellation. You can have good control. You can ensure that your bladder stays distended because you can see it. And you want to make sure that the blades aren't inadvertently pointed in a direction where they could cause damage. But anything that's red can bleed, so I just take the time to be very diligent to control the bleeding. And I'll do this either by using 2 joules and 60 hertz and defocusing, or 2 joules and 20 hertz and actually touch the tissue. Usually use 2 joules and 20 hertz at the bladder neck and 2 joules and 20 hertz near the sphincter, and then everything else I use the 2 and 50 or 2 and 60. So I am just going to burn that surface there near the bladder neck to even out. And then I see that there's this last little nodule here, so I want to, somehow I didn't connect that in, and I'm going to take that out just so it looks nice and pretty at the end, and just burn that off. So once I get this little nodule out, then I'll morcellate. Currently, there's really only 2 morcellators on the market. We have the Wolf morcellator and then a disposable morcellator. I prefer the Wolf morcellator. I think it's very efficient and good for these really big prostates. Okay, so it's fully released there, and the ureteral orifices are intact and safe, and we have very little bleeding left. When I switch to morcellation, I want to make sure that I have 2 inflows. The only outflow is the morcellator, and that's to ensure that the bladder stays super distended. Some people worry about the bladder being over distended, and in reality, these are BPH bladders. They're very thick walled, and we're using only gravity irrigation. So perforation of the bladder through irrigation alone is unlikely, and I've frankly not seen it using gravity irrigation. I'll use 3 bags. I have 2 5-liter bags that are wide to a wide tubing, and then a 3rd bag that's in a single tubing, and both of those are attached to the nephroscope so that I have maximum inflow, and the only outflow is the morcellator. I don't use any pressurized irrigation or fluid management systems. I feel like gravity's never betrayed me and it's always reliable, whereas pressurized irrigation systems or fluid management systems rely on a pump and a feedback mechanism, and sometimes you can get overpressurization or underpressurization. So because I took the time, I found these two big pumping bleeders near the apex that could really cause issues later. So even though it feels like you're taking a long time drying up, it's so important to just control the bleeding and look everywhere. Anytime there's clot, I will try and roll that clot up to make sure there's not a pumper underneath. And the laser does a great job using that burst wave of fluid to control it. Now, sometimes I will just control if there's a big pumper on the Veru. I will take care of that with the laser as well. But I try not to do much lasering apically on these cases. You can see the capsule's actually collapsing down because it's so big. You can see the large lobe just floating in the bladder almost fills. The two prostate lobes actually almost fill the entirety of this gentleman's bladder. So it's not surprising that a minimally resective procedure did not work well for him. But he'll do great with his whole lip surgery. And sometimes I'll turn the fluid off to make sure there's not an area that's oozing, as of right there, just to find anything that could be problematic later on. And a little fluffy adenoma that I'll take care of here as well. Now the flow is off, and I can see a few little streamers apically, which I'll get at 2 joules and 20 hertz to ensure that that's clear. So I'm switching over to the morcellator. And morcellation is done with an offset nephroscope. So the focus is a little different. An offset nephroscope combines rod lens with fiber optic because the eyepiece is offset, whereas our regular laser scope is rod lens. So the view is not as good as your regular laser scope, and that's why I spend so much time drying up. Even with all of my efforts, it's still a little oozy when you change and you can't see as well. This is mainly because I have 2 inflows and the only outflow is the morcellator. So until I start morcellating, there's not continuous flow. So now I've got the morcellator in place. I've got the tissue above me. I'm sitting right at the bladder neck. And the perfect view is just seeing the ears of the wolf. There's a wolf that is engraved on the tip of the blades. And I want to see that black line or just the ears. And that's the perfect distance to morcellate. If you see the whole wolf sticking out, then it's too far out and you can damage the bladder. If you don't see the wolf at all, the blades are too close to the tip of your scope and the tissue will keep bouncing off the end of the scope and you'll be super inefficient with your morcellation. So trying to keep it right at that perfect level where you just see the ears or the line is where you want to be. And I'm going to work at the bladder neck and I'm going to keep the blades low. You want to keep them almost parallel so it's easy to balance the tissue above you. And the vortex flow of the fluid will actually push the tissue down to your morcellator. So you just want to be very steady and patient. And as the tissue gets bigger, I try to pull it back into the fossa. By pulling it back into the fossa, I can then morcellate it in a tighter space. And that is easier as well. You can see the tissue's too big to do that just yet. So I need to morcellate it a little bit more in the bladder before I pull it back into the fossa. But being patient and checking every so often to see if it will pull into the fossa is what I do. Pulling it into the fossa creates a tighter space so the tissue can't float away when it loses suction. Also, if you create those little beach balls, they're very easy to find right in the fossa. But you can only morcellate in the fossa if the fossa is dry. If it's bleeding, you can't do it, which is another reason to do the drying up at the beginning before you morcellate. So this piece is actually quite scarred and rubbery, which is making the morcellation more difficult. And it's kind of morcellating into a flat piece of tissue, which is unique. Usually it morcellates into a nice round ball, But in this case, it's a flat piece of tissue, and that's just a testament to the amount of scar and inflammation that's in this tissue. I believe in this case we got 150 grams of tissue, which is more than what I would have anticipated with a 160 pre-op volume. So probably we underestimated the size, or this tissue was more dense. It's not a one-to-one conversion from size to weight. Some tissue is more dense, some is more watery or glandular. So you don't always know exactly what you're going to get out. Now I've been able to pull that tissue down into the fossa. And when I pull down into the fossa, I actually drop the morcellator posteriorly. You can touch the back wall of the fossa with the morcellator. It won't grab the tissue. The fossa or the capsule is very dense, so it's extremely difficult to morcellate it, and this is a safe place to morcellate as long as you can see. You can also tell I'm in the fossa because there is a little bit more oozing as I work. So that first lobe is done, and I'm just going to complete the morcellation with the second lobe here. I'll also be able to remove blood clots that have developed in the bladder as I morcellate. The morcellator is great at removing blood clots, especially if you get in a situation where someone comes in with a large bleeding prostate and a bladder full of clot. As long as you feel confident using a morcellator, this will be the most efficient way to do that clot evacuation. I wouldn't suggest that you do it as the first time using a morcellator. This piece of tissue, again, is morcellating better than the other piece of tissue because we've created space. I feel like the whole lip surgery is all about creating space for the other lobe to enucleate, creating space for the other lobe to morcellate. The more room you make, the easier things get as you go along. But this patient was on finasteride for a long time. He's had a prior surgery, so the tissue is much more rubbery than standard prostate tissue. If you're having a hard time getting the tissue to morcellate, there's a few things you can do. One, you can cut grooves into the tissue to create more surface area for the morcellator to grab onto. That's usually if you're dealing with really small pieces of tissue that you just can't get out. You can go back to the laser scope, cut those grooves, and give an edge for the morcellator to grab onto. If the tissue is really dense, you can also just put a catheter in and run irrigation for a day, keep the patient in the hospital, and then bring them back to morcellate the second day. Running irrigation will soften the tissue, make it much, much easier to morcellate, and it usually goes very smoothly the next day. I think, one concern I had was that it would clog the catheter. It's so rubbery, it doesn't get in the way of the catheter, and you can run the irrigation without problem. And then the third option is just opening the patient to remove the adenoma. So if it really will not morcellate, you don't think it will soften with irrigation, you can always make a small cystotomy, take out the adenoma, and then close everything up. I wouldn't recommend doing that unless you've talked to the patient ahead of time about that. So this stop in the video right now is us changing the canisters. So with morcellation, you can only suction out so much fluid, and then you have to change the canister. So the canisters are 3 liters in size. So once you hit that 3-liter mark, you have to disassemble the morcellator, change out the canister, and at that same time, you should change out the tissue trap. That will increase your suction and improve your morcellation efficiency. Hopefully with newer versions and newer morcellators, they'll limit that 3-liter canister issue, but right now we have to deal with that. They do make larger canisters that are 5 liters, but at 5 liters you have decreased suction and the tissue trap still gets full. So 3 liters seems to be the sweet spot for the canisters. It's usually about 90 seconds to change the canisters, and then you can get right back to morcellating. So we will just finish out this last lobe of tissue with morcellation, and then once this tissue is removed, we'll go back and do a final dry up. I use a 22 French 3-way catheter at the end with 40 to 50 cc's in the balloon. We are now doing the procedure under monitored anesthesia, so just a deeper sedation that is almost like a colonoscopy, maybe slightly deeper than that, and that has really helped us to get the patients out of the hospital. So we're able to leave the catheter in 1 to 2 hours, take the catheter out, patients urinate 2 to 3 times. We check the color of the urine, make sure they're emptying their bladder, and if everything looks great, they can go home that day without a catheter, which is pretty amazing, especially in this particular case where this patient has an enormous prostate. So after morcellation is complete, then I just do a final dry up. It will look so dry before we morcellated, but then, as you morcellate, you're overdistending the capsule and the bladder. So some of the areas that I controlled the bleeding before I morcellated have started bleeding again. It's very common. You want to take the time to dry up one more time if you're going to get the catheter out that day. I will also remove any clot to ensure that there's not a bleeding vessel underneath it, and then check the sphincter area to ensure there's not a large pumping vessel close back by the sphincter, and check the bladder neck really well too. With some surgeries, you don't want to do a lot of cauterization near the bladder neck, but with HoLEP, the bladder neck is so wide that you can control those bleeders and get great hemostasis because you're not going to get the scar tissue. If the bladder neck does look tight, I will make an incision at the bladder neck at this time, but obviously this patient's prostate's so big, we don't need to do anything like that. He has a nice wide open bladder neck, and his risk of bladder neck obstruction is extremely low. So I've turned off the flow now, again, just checking for any bleeding to ensure that there's not an area of significant bleeding. And that's it. We are done. So in this particular case, the patient was so happy. I did his surgery. He had his catheter in for approximately 2 hours after the procedure. Catheter was removed. He voided multiple times and went home that day. Within 2 weeks, he was back to full exercising, not leaking, excellent stream, just extremely happy with his outcome.